All right, it's my privilege to sort of set the stage and sort of recap a few things. So let's dive into that real quick. And in case you needed a reminder, not to dwell on this, but here's the problem we're trying to solve. The United States spends an awful lot more money than they get the value in terms of years of life. And it's kind of interesting when you look at it, we're roughly about twice the average in terms of costs. If we were living twice as long, we'd all be like 160 years old. That's kind of cool, but anyway, it's kind of unaffordable, and even if that were possible. So here is the problem we're trying to solve brought home, that up to 20% of the GDP and more, if unchecked, ultimately crowds out other very important social programs and things that we want besides healthcare. So we got to solve that. That's the problem we're trying to solve. Now this slide is something we've been showing a lot lately over the last year or so, trying to set the stage and the expectation that we believe the solution is here, moving towards something like capitation or global payment. And we've identified a few objectives. And as we've been talking about this, things started to happen, like payment transformation. A very aggressive move by HMSA is being introduced, not just for primary care, but for specialty and surgical care too. That's starting up now. They're beginning to think about that. No, don't worry, guys or gals, they're not implementing it yet, but they're starting to think about how they're going to do that. CMS has introduced some major changes and now are full on into this merit-based incentive payment system, which is the derivative of PQRS. And along bounced this thing called CPC Plus, Comprehensive Primary Care Plus, which was really quite a big event in the community. And then along with that was a Medicare Shared Savings Program and a bunch of different variations and tastes. I think it's probable that MedQuest, Medicaid is on this trajectory eventually as well. And you hear remarks out of the new directors that are entertaining that. So what does it all mean? It's happening. What we said might happen looks like it is happening. And even though it's a little bit of a cartoonish, I do think the programs are laid out more or less along the timeline that we might expect to see them. And we are doing great. We are on schedule and we're making good progress on that. And you're going to see that tonight, that even though it's complicated, I'm excited about our potential to do well with that. But admittedly, sometimes it kind of feels like this, that it is a little bit of strange waters, and we're going to need to learn how to swim. So what I'd like to do is spend the next few minutes telling you about some of the work that's being done. And remember, 2014 was about setting up the operation. 2015 and up to now is about beginning to make the operation hum. In 2015, we said that there were 5 key projects that needed to get done. There were complex care, primary care redesign, chronic kidney disease, high-intensity diagnostic imaging, and avoidable ED utilization. And I'm excited to have you hear some of our physician leaders who stepped up to that challenge. So that's really what it's going to be about mostly. But without stealing their thunder, I wanted to kind of call your attention to some of the things that they're not going to cover. So this year we were able to launch the new updated website. Looks great, don't you think? It's very cool, very slick. And obviously, the more communication we can have, the better. If we intend to build a community and a shared vision, it's vital that there's a lot of communication. So we have things like listservs. This is the one that's going out now for primary care redesign to all primary care docs. So they have the opportunity to partake if they want and participate in the dialogue if they want about those big changes. There are, of course, newsletters and CMEs, which we have a nice, robust schedule laid out for the year and have been increasingly well attended. I want to point to the next big event, which is about 6 months from now, March 2nd at Kapiolani. We'll have this thing called the Hawaii Health Partners Forum. It'll be a departure from this kind of a stand and deliver. We expect it to be a little bit more hands-on working sessions where we maybe will come up with new standards of care for the Hawaii Health Partners community. We also would like to entertain looking at some maybe medical controversial things so we can have a very interesting and fun dialogue about that. So here's another important tool to look at, another development. This is the Hawaii Health Partners dashboard. This is a very important asset that provides great input and direction. Janny Chang has been very helpful to us in getting this, and when it's used, it goes well. Here's a graph on the left that shows you the uptake since its introduction by primary care docs and by all users. And when you use it, you don't have to use it, but what you see on the right is a real-life example of one doc and one MA who were maybe not doing as well in quality as they wanted to and started to look at and use this tool aggressively. And it's not that either one of them has to do it, but they have to agree on how do we measure what we're doing and get better at it. It works. It's potent. Here's another tool in the dashboard. This is another page or another tab called the Avoidable ED tab. So those are the tabs across the top. And this one also is showing people, giving them some real feedback about what's happening with the avoidable ED volume. So you see the percentage and whether or not it's very avoidable or maybe not so avoidable and what it's doing over time and how that compares to their peers. And when people start looking at this, it goes down as well. This isn't just one PCP working on it, this is everybody. And we started off this program really in earnest. The first data point was really around 36%. And we're at 31% now, so lower than a third. It's not like earth shaking, but it's real. It's pretty hard to dispute that that is lower than what it was when we started. Part of the success of that is looking at people who have lots and lots of ED visits. And there may be very good reasons for that. And there may be very good ways that we can help people who have complex medical conditions that are basically looking to the ED as a rescue strategy. So that is where we get into complex care. Some of those people find their way into this program. Now we've always known, this is a bit of a busy slide, but the bottom line is this. So we've always known that providing complex case support has a real benefit to people. But what we weren't as confident about is whether there was a financial return on investment. And what this has now shown is that in a case control type of a construct, we have a real difference for the HMSA commercial population. And so we will build on and expand on that. We have a great team, a very wonderful, conscientious, devoted team of care coordinators that are assigned to and work closely with primary care docs and their teams to ensure that the ambulatory quality performance is good. And so you can see here that there was a very nice steady trend upward through Q1 of 2016, and what changed was the measures and the membership. So we add new docs, and so you have to kind of reset a little bit in all regards. But it's steady progress, and here's what's maybe more important than any of that individual stuff. At this level, there is no other large PO that's achieving this level of quality. It is great to achieve quality when you're a small group, not to take anything away from that. But it's a whole different thing when you're talking about trying to achieve quality with 130 different PCPs in a way that supports their individuality and still leverages great centralized resources. Now the busy graph across the bottom is showing you all of the different measures. And without trying to break your eyes looking at it, the tall bars are more important than the smaller bars because there's more at stake. And you'd like to see the blue bar as high as the gray bar. When we studied this and we looked at where's the impact and where's the opportunity for improvement, it really kind of focuses us on these three measures for the coming year. Now we will, as always, pay attention to all the measures, but these are the three that are going to enjoy special attention: hypertension control, cervical cancer screening, and A1C control. The graph on the right is just an illustration of how we track that. We have similar things for all of the measures, but we know how many we need to get to goal in order to hit the 90th percentile. So I'd like to switch now to happy news. That's all happy news, but this is even happier news. We have this QPP-SSP program, and it pleases me greatly to tell you that the check is in the mail. You should be getting a bonus this year, and that, on the next check run, those checks will be cut. And if you're ever looking for the details about this program, you can go back to that fancy website and find all the detail there that you want. But here's the bottom line for 2015's payout. It's about $3.05 million is being paid out in bonuses this year. And the average payout per doc is about $4,500. And the range is huge. The range is anywhere from like $1,000 up to $20,000. And the top end of that range is really because those are the physician leaders who've stepped up and volunteered as chairman of these various work groups. So there's something for everybody, depending upon how much and how active you want to be. The graph on the left shows you the display or the spread across the various campuses and how much opportunity in the orange was left on the table. The pie chart in the upper right is a breakdown between specialty and primary care. And not surprisingly, when you look at the bar chart on the bottom right, there are a lot more specialists and surgeons. So even though their average dollar amount per doc was $3,500, the total amount is much larger than the PCPs, who had a higher per average payment of $8,300. So that is really good news. Now, how did we get that? This is how we got that money. We got that money because quality performance was really quite good. Our goal was 70%. As a system, we hit 77%. That triggered the funding of the quality bonus pool. Every hospital needed to be above that threshold, and every hospital was. So every physician that is a hospital-based specialty and able to earn points under QPP received a bonus. On the SSP, it's a different game. It's kind of a simple game, not easy to win, but a simple one to understand. It's basically beat the community. And so the blue bar is us, and the orange bar is the community. And what we need to do is show that our medical cost trend, that is our year-over-year expense, is rising at a rate lower, less quickly, than the community is. And so the bottom left shows you that for the HMO population, the blue bar is significantly lower than the orange bar. And so now there's a shared savings payment. That feels really good. That's awesome. That's unbelievable. And we were just getting started with this. We haven't really applied a whole lot of energy to it. Just as a reminder, here's what last year was. Last year, we did beat that 70% threshold. One of our hospitals, unfortunately, didn't quite make the threshold. And notice that last year, it's the one on the right. It's the PPO population that funded the shared savings program. So there's a lot of movement in there. And it doesn't get easier. In 2016, the bar is raised to 75%. That's going to be hard. That's going to be difficult for us to achieve. The MCT actually the medical cost trend might actually be the easier way to go. And so what I want to do is spend the last few minutes kind of talking about that. Because we find ourselves in a bit of a strange situation, right? Like, we know quality is good. How do we get good on shared savings and medical cost trend? So what I want to do is give you a few examples to think about and start to actually explore actively in the coming year. 6 of them, to be specific, with a couple of others thrown in for good measure. Number one, we need to explore what diagnoses, procedures can be moved to a different location. What location would make sense, and how would we go about doing that? We need to avoid unnecessary care. Overuses or misuse, that's clear. We're pretty good at addressing underuse. Not quite as experienced or aggressive about overuse. Specialists need to be compensated for referral agreements, care coordination, e-consults, and appropriateness scores. This means that people are getting done exactly what needs to be done, not a whole lot more, with great coordination. Another example of that you'll hear about tonight is diagnostic imaging appropriateness and the aggressive embracement of decision support rules. Complex care, we've just said, is something that works. So let's make sure we use it on the right rising complexity cost patients. And let's continue to work on decreasing ED overutilization, which is not just about primary care. It's about new partnerships to think about how do we extend the reach. There are a couple of other things I think are very important. They're not a direct impact on the cost of curve or the cost of care, but still vital. That is, we have to have accurate coding and problemless maintenance, because that ends up driving the severity in the HCC score, which ultimately influences your payment. And lastly, and very importantly, we need to start paying very careful attention to which patients are ours. They're all our patients, but kind of some of them might be a little bit more ours than others. They look to us and have committed to us to be their doctors, their system. And similar with other physicians and specialists that have joined you in this community. So know who's ours and play to those strengths. So to close it out, I just wanted to make sure that you saw yourself somewhere in that short list. Where is your specialty? I think all specialties can participate in accurate coding and problem list maintenance. Know something about the HCC, know which patients are ours, be appropriate in ordering. Surgical specialties need to start exploring. What does it mean to find a best value location? And is perioperative surgical home and enhanced recovery, that's a big deal. That is a big direct and indirect savings on cost as well. Adult ambulatory and specialty, we've got programs that are getting set up in terms of finding the referral agreements that will be efficient. And hospital base, I think, has already had some dialogue about identifying avoidable admission opportunities. Pediatrics and adult primary care have already done good stuff and should continue to build on their success in ED overutilization and complex care. And to help all of that, we're introducing a little bit more leadership structure to organize that activity. So the 12 people, actually it's not 12, it's 10 people that you see here are assigned, have agreed to take a leadership role in these 6 specialty categories. So Monica, Donald, Amy, James, Dina, and Keith will be the physician leads helping organize activity that we hope will help us succeed with all of this. And in fact, for success, here's what I'd like to see by this time next year. Let's see if we can have a total cost of care that is clearly lower, not by randomness, but by attribution. We can see that our efforts, we have great confidence that it's making a difference. That we see more bonuses on both sides of the HMSA payment transformation as well as for us. That we see objective evidence of great appropriateness and coordination. That PCPs are enjoying the support of a team-based care and succeeding in that new payment model. Specialists and surgeons are seeing the patients that are very appropriate with very good workups prior. And that hospitals are now managing a successful transition to cope with changes in utilization. That's all. No big deal. It's a big deal. All right, so here's a question. Now we're going to test, see if you figured out your technology. You guys are going to take it from there? All right, so which of the following is going to help improve value? Understanding and encouraging clinical decision support in Epic. For your specialty, knowing what diagnoses are important in calculating severity. Helping keep a good problem list on a patient's record that's current and accurate. Or filling your hydro flask, if you've opened up your bag, your hydro flask with something exciting and auctioning it to the highest bidder. So please enter your answers now. We can't track you if you answer D, so you're safe. It's all right. All right, well, it looks like pretty good teamwork here, focusing in on the problem list and the HCC coding. That's excellent. If you guys do that, there will be a real benefit this year.